Welcome, everyone. We're delighted that you can join us today for this joint webinar between the International League of Dermatologic Societies, the ILDS, and also the U.S. Centers for Disease Control for Fungal Awareness Week. This morning, what we're going to be discussing is drug-resistant dermatophytes and the emerging outbreak. And I'm very excited for our first speaker to give us an overview. We have Dita Sante joining us from Denmark. And with that, I will pass it over to you. Dita, I think you are muted.
I'd like to share my screen with you to see. Sorry.
And while Dita is sharing her screen, I'll just share that Dr. Sante is from Denmark and is a world expert in fungal diseases. And she also serves on the European Academy of Dermatology and Allergy. And so we're so lucky to have her today. She's really contributed to our knowledge of fungal diseases and particularly superficial dermatophytes. And with that, I'll turn it over to Dita.
Thank you. And you see my screen, all of you, I hope. I'm very happy to be able to make this introduction to antifungal drug resistance. And before we go into detail with that, I'd like to introduce tinea. Tinea is a dermatophytosis, also called ringworm in English. It is a fungal infection caused by a dermatophyte, and it is a keratinophilic fungus which can affect skin, hair, and nails. It's a primary pathogen. And common diseases caused by it is a tinea pedis, also called atlet foot, tinea corporis in the body side, tinea capitis in the scalp, and tinea unguum of the nails. There is a very high prevalence of tinea. Up to 25% of the world population is affected, and it can be transferred in different ways. A zoophilic infection is transferred from an animal, for instance, to a human. We have the geophilic from the soil, keratinophilic keratin in the soil is transferred to humans, for instance, at the hand of people working on the land site, farmers. And then we have anthropophilic, which is transferred between humans and can cause epidemics. So this is just a glance of the history. We have Trichophyton rubrum, which was distributed worldwide from the late 19th and early 20th centuries, from the south east Asia and from the west of Africa, with immigration and migration and through wars to the rest of the world, and is now the most prevalent species worldwide, causing tinea pedis and tinea unguum. So normally these infections are very easy to treat. We use topical treatment for localized infection and systemic treatment for more widespread infections, or for tinea capitis or onychomycosis. To the right, I have a very simple drawing of a fungal cell. We have the cell wall made of manoprotein and chitin and beta-glucans, and we have the cell membrane made of ergosterol. And the antifungal agents are working in the pathway from making squalene to ergosterol, the cell membrane, and they're working in different level, where we have the terbinafine, which is interrupting one of the pathway, and we have the azoles, which is blocking a later step, and then we have the cresifulmin, which is working and interrupting mitosis in the chromosomes. And now we are seeing what is happening here with me. Sorry.
We can still see your slides.
Okay, because I can't. Okay, thank you. And then I have here that there's emerging antifungal drug resistance now occurring. So we have different kind of resistance. We have the clinical one, where there's no response, even though the dose and duration of the treatment is correct. And then we have the mycological resistance, where we have primary intrinsic resistance and secondary acquired resistance. When we have a clinical resistance, we have an infection. It can be an infection with a drug, where a drug-resistant dermatophyte, but there can also be other reasons, such as antifungal drug is not absorbed which can happen with itraconazole. We have antifungal drugs which are not able to penetrate an area. For instance, at the picture here, where we have the nail with a dermatophytoma, it's very difficult for the drug to penetrate this clump, massive mass of fungus. Then the patient can be reinfected, and we can also have patients who are non-compliant. So that was the clinical one. Then we'll look into the mycological reasons for anti-drug resistance. And we have the primary interesting one, which might be this new species called Trichophyton indutinae, which is a very contagious species, which is responsible for chronic and very recurrent widespread superficial infections. It can be identified by molecular diagnostic only, and it has a known mutation in squalene epoxidase in lots of the isolates, and up to 75% of those are terbinafine resistant. And the illustration to the right is that it has been hypothesis that it has been transferred from the soil to animals, and from the animal to human, and then a new species has occurred, which is now Trichophyton indutinae, and it's difficult by culture to identify because it looks a lot like Trichophyton mentacrophytes complex. Then we have the secondary acquired resistance, which can occur after antifungal exposure. Here, this is illustration of a fungus which is susceptible, and then the arrow indicate antifungal therapy. We have different length of therapy, both topical and systemical, and over time, resistance will evolve. So this is caused by incorrect application of antifungal therapy or a subtherapeutic exposure to the antifungals. Also, environmental factors such as antifungal use in agriculture can contribute to this. So in summary, we have antifungal drug resistance. We have the clinical one where there's no response even though the dose is correct. We have Tinea indutinae, which is a primary intrinsic and is a new and emergent species with a high frequency of terbinafine resistance, and it is identified by molecular diagnostic methods only. And then we have the secondary acquired antifungal resistance due to subtherapeutical and incorrect antifungal drug exposure. And with that, I would like to thank you for your attention.
Great, thank you so much, Dr. Santé. It was an excellent introduction to a very complex topic. Next up, we're going to be changing gears, actually, invite Dr. Santé back for her next presentation. The next section is going to be focusing on cases and stories from the field. We're going to have 3 different speakers join us for this section to share their particular experiences. First, we'll be discussing treatment and treatment failure in Europe. And next up after that, we'll be talking about tinea and Cox's Bazar. And finally, we'll be talking about the experience in the United States. And I should mention, apologies for not doing so earlier, my name is Dr. Esther Furman. I am a global health dermatologist based at Massachusetts General Hospital here in Harvard Medical School, and I'm the vice chair of the International Foundation for Dermatology. And with that, I will pass it back to Dita. Thank you so much.
Thank you so much, Esther. And I'm going to present to you emerging antifungal treatment failure of dermatophytosis in Europe. And I was invited to do this talk mainly because of this paper, which was from 2021, which was made due to members of the EDV mycology task force were talking about that we saw a number of patients which failed for the treatment, antifungal treatment of very simple dermatophyte infections. So we were wondering if antifungal drug resistance was an overlooked problem in Europe. So what we did was to ask this question to our colleagues over Europe. Have you seen a patient with tinea capitis, tinea corporis, or tinea cruris who had failed to respond to oral antifungal at doses and treatment duration which could normally clear the infection, or would have who have relapsed within 4 weeks of stopping of treatment? And if you notice here, we did not ask to onychomycosis, as is a different setting, which can often treatment failure due to other things than antifungal resistance. So 23 countries were invited to give this to this survey, and 20 responded. And of the 20, 5% had observed antifungal resistance. You see that here on the figure of the orange areas, and also you see a blue area, which is countries which had published in antifungal resistance at that time when we did this publication, and the green area here is a country which this year has been making a publication on antifungal resistance in their country. So it's probably more widespread than on this figure. So what we also find was 96 cases, and most of them were terbinafine resistant, 64%, and itraconazole, the second most resistant antifungal treatment where the dermatophyte were resistant to, and then fluconazole 16% and glycifulvin 4%. And in the trichophyton species, 75% of them were terbinafine resistant, which is kind of a problem because terbinafine is first-line drug for treatment of trichophyton infections. Moreover, I want you to notice that antifungal susceptibility testing was only available upon request in 55% of the countries included in this study. So what we saw here might be a top of the iceberg. We found that clinical or mycological proven antifungal drug resistance of dermatophytosis were present in 85% of the included European countries. And since then, there has been more studies in Europe. Here is a new publication from this year where the numbers of countries are listed where they have confirmed terbinafine-resistant trichophyton endotheniae. So you see here that this new species is spreading in Europe as well. And also, we have a lot of other publications on the subject. I want you to look into the one here in the corner with Microsporium arduinii, where it has been found clinically resistant to glycifulvin and also have high MICs. Unfortunately, we don't have breakpoints for Microsporium arduinii and glycifulvin yet. The others are within the trichophyton mentacrophytes complex. So with this, I'd like to sum up my talk. We have here antifungal drug resistance, which is widespread across Europe. We have multiple different dermatophyte species which have been proven antifungal drug resistance. And we have also, I think it's very important that we have further research within this subject, and surveillance is needed. And I know that Professor Esther Freeman is giving a talk upon that later today. With that, I'd like to thank you for your attention. Thank you.
All right, thank you very much, Dr. Sante. I have so many questions. We'll wait for the Q&A until the end of this session. We'll be changing gears now, and I'm very excited that we will be sharing the experience out of Cox's Bazar, so a different section of the world. And this will be Dr. Sidra Khan, who is based in the United Kingdom, will be sharing her experience, particularly with migrant health population struggling with some of these challenges. And so with that, we will pass it over to Dr.
Hi, my name is Sidra. I'm a dermatologist based in the UK, and today I'll be speaking on dermatophyte treatment failure in Cox's Bazar, Bangladesh. Here are my disclosures. So just before I get started, I wanted to provide a brief overview of my talk. I will provide some background on the setting and the patient group, an overview of the project which started back in 2019, the ongoing developments in our work and our future plans, and really how dermatophyte treatment failure has been a big part of this work throughout. So starting with some background. For those who may not know, Cox's Bazar is in southern Bangladesh, just neighbouring Myanmar. Following the outbreak of violence in the Rakhine state in August 2017, hundreds of thousands of individuals fled into neighbouring Bangladesh, entering the Cox's Bazar district. Very quickly, this became one of the world's largest and most densely populated refugee camps. Living conditions were harsh, and so infectious diseases were common. During the acute phase of the influx of individuals, conditions such as fevers of unexplained origin, respiratory infections, and acute watery diarrhea made up the top 3 most common presenting complaints to primary care facilities within the camp. Interestingly, though, skin disease during this acute phase was the 4th most common reason for presenting to primary care facilities. Later in 2022 and in early 2023, similar reports demonstrated that skin disease was the most common presenting complaint in the camp, making up between 29 to 25% of all presenting complaints to primary care facilities within the camp. There have been multiple large-scale outbreaks of scabies within the camp, particularly in recent years, and that's of course important to mention when considering the more recent figures. However, that is not the complete picture. In late 2019, we were approached by organizations on the ground who noted the high rates of skin disease that they were seeing in patients in the Cox's Bazar refugee camp, and they reached out looking for specialist dermatological input. And so in 2019, members of the International Foundation of Dermatology's Migrant Health Group and dermatologists from the University of Chittagong entered the camps to run dedicated dermatology clinics. Here is the breakdown of our data from the Skin Disease Needs Assessment Analysis in 2019. As you can see here, we saw almost 400 patients across 3 days and made 457 diagnoses. The top 3 categories of diagnoses were fungal skin infections, dermatitis, and bacterial skin infections. Interestingly, the top 3 categories of diagnoses made up almost 80% of all the diagnoses. This is of course important to reflect, as we know that the most common skin diseases account for more than 80% of the burden of skin disease in skin NTD endemic areas. So you may have noted in the last table that the single most common clinical diagnoses during the skin disease needs assessment analysis was dermatophytosis. This made up 47% of all clinical diagnoses. What was interesting was not only the amount of dermatophytosis we were seeing, but the clinical presentations. Patients were presenting with extensive disease involving multiple body site areas. Another interesting finding that we noted was that we were also seeing cases occurring in familial clusters, so parents and children affected, for instance. And here I have a clinical image kindly provided by Dr. Valeska Paravesi demonstrating exactly that. One of the cases that we saw, female patient with really extensive scaling patches with an advancing annular edge across her trunk and her legs. So we were actually able to take some samples back to the UK for analysis. The Mycology Reference Lab at the University of Manchester kindly were able to process some of the samples, and for 7 of the 8 samples that we brought back, the culture report demonstrated T. mentegrophytes / T. indigitale, and of course we now know that this is almost indistinguishable from T. indigitale on culture. And it raises the question, what we were seeing, was this really T. indigitale, and were, these cases potentially demonstrating dermatophyte resistance? This, of course, raised a number of questions. Firstly, within the camp itself, there were no facilities for diagnosis. There are no microscopes. There's not even, the option to try and just do direct microscopy. Then if you're even able to make a diagnosis, you have very limited options when it comes to therapeutics. And then additionally, within that particular area, there's a real concern about the widespread availability of low-quality generics, and raises a question of what role do these play in the development of dermatophyte resistance. And then, of course, within that specific region, but in the wider local region, there is, of course, the concern about the widespread use of fixed-dose combination treatments of topical antifungals with things like topical steroids and antibiotics, and again, what role these play in the development of dermatophyte resistance. So the question was, what next? So one of the outputs from this work was to set up a teledermatology project. After securing a grant from the International League of Dermatological Societies, our group was able to set up an asynchronous teledermatology pilot that ran for 6 months. Patients attended the primary care facility and saw their doctor. The doctor was able to enter the clinical information and photographs securely, and cases were read remotely by a dermatologist, and the patient then returned a week later to collect any treatment and receive a diagnosis. So the teledermatology pilot ran across a 6-month period out of a single facility. and 310 recommended diagnoses were made for 282 patients in total. And the top diagnoses did not look too different or too dissimilar from our initial skin disease analysis report from 2019. And once again, dermatophytosis was the most common presenting complaint via the Telederm service. Just very quickly to mention that there have been, of course, some hurdles along the way. The COVID-19 pandemic at the very start of the project had led to some delays. There was an 80% reduction in international humanitarian staff throughout the camp. Of course, local politics and the constant changeover and turnover of staff has also impacted the work that we're doing. So going forward, we are planning to expand the teledermatology service from one clinic to running out of 3 clinics. We are also hoping to increase the number of clinics and dermatologists reading cases. We are hoping to also employ a part-time telederm coordinator who can help take some of the administrative burden associated with the program off some of the clinical staff. And then hopefully returning to Cox's Bazar maybe later in 2024, although that seems unlikely right now, and perhaps early 2025, depending on the political situation on the ground. And then when we do return, we are planning to run some workshops and seminars and train up and upskill the staff on the ground. So just to summarize, skin disease, specifically dermatophytosis, continues to be a real problem affecting patients in the Cox's Bazar refugee camp. By improving access to dermatologists and upskilling staff on the ground, we hope to be able to improve the accuracy of clinical diagnoses and reduce inappropriate prescribing of medications that can potentially worsen rates of dermatophyte treatment failure. Thank you very much for listening, and thank you to all of our supporters on this project.
Thank you so much, Dr. Khan, for such an interesting presentation about the experience in Cox's Bazar and the continued challenges in this area of the world. Next up, we're going to be hearing from Dr. Abram Kaplan. Dr. Kaplan is an expert in fungal diseases based in New York City, and he was one of the first to recognize the person-to-person transmission of drug-resistant dermatophytes within the United States. We're very delighted that he's joining us from NYU today. Over to you.
Thank you, everybody, for being here, and thanks for the opportunity to be a part of Fungal Disease Awareness Week. Today I'll be discussing Trichophyte endotiniae and Trichophyte mentagrophytes ITS genotype 7 in New York City. I have no conflicts of interest. We'll start today with T. endotiniae in New York City, and then we'll turn to T. mentagrophytes ITS genotype 7, or what we'll now call TM7, and a brief overview of epidemiology, clinical clues, and treatment. Here I'm highlighting the MMWR report from 2023, reporting the first 2 confirmed cases of T. endotiniae in New York City. But before we drill that, let's just step back and look at this paper that was also published in 2023, a review of lab data of dermatophytes from across North America and a retrospective search for T. endotiniae. Of the 271 isolates, 18.6% were defined as terbinafine resistant based on an MIC value greater than or equal to 0.5. Notably, 21 isolates were T. rubrum. Now, we're not going to talk about T. rubrum today, but we know there's increasing terbinafine resistance in T. rubrum, which is of concern considering this very common dermatophyte. But you also see 21 isolates for T. endotiniae, the earliest being from 2017. We'll turn back now to T. endotiniae in New York City, and I'll highlight some of the findings from this paper in JAMA Dermatology in July 2024. We reviewed 11 patients with confirmed T. endotiniae, along with New York City and New York State Department of Health, CDC, and colleagues from medical centers across New York City. The median age of patients was 39, 6 male, 5 female. 9 patients reported travel in Bangladesh. 1 reported no travel, suggesting the possibility that she acquired T. endotiniae here in New York City. And 1 patient was lost to follow-up without any travel information. Household transmission was considered highly likely in 3 instances. And U.S. isolates formed a distinct cluster from known Indian isolates, highlighting that these patients likely acquired the infection in Bangladesh. The most common sites of involvement were the trunk, extremities, buttocks, and groin, and most patients reported itch and the use of topical steroids prior to the tinea diagnosis. This correlates to what we see in the literature. When we looked at treatment, patients received a number of different therapies. And I'll just point out that some of these therapies were chosen before clinicians had been able to confirm T. endotiniae. Terbinafine was treated, 7 patients were treated with terbinafine at 250 milligrams per day from a range of 14 to 42 days. No patient responded. And you can see the MIC values ranged up to 128. 4 patients were treated with fluconazole, 2 responded. We only have MIC data for 1. You can see that noted here, in a patient who responded after 200 milligrams weekly for 12 weeks. 5 patients were treated with griseofulvin. 1 patient responded. The MIC here is 4 with a dose of 375 milligrams per day, and 1 patient improved. Among the patients who didn't respond, you can see the MIC value here is 4. And finally, itraconazole was used in 7 patients. 3 had resolution of infection with a low MIC value, and doses typically 200 milligrams per day. Now, before we move on, I'll just highlight that the literature, largely from India and Europe, suggests very high MIC values for fluconazole and griseofulvin, and that these are not the ideal treatment choices for trichophyte endotheniae. Turning back now to our first 2 confirmed cases, you can see this particular patient has tinea corporis and tinea cruris, acquired the infection in Bangladesh. You can see that she's been using topical steroids, and you can also see that from some of the morphology of the lesions, where you see this ring-on-ring appearance. Many family members have the same rash, and routine culture shows T. mentagrophytes. And we know routine culture can't distinguish this from T. endotheniae, which requires genetic sequencing. And she fails 4 weeks of oral terbinafine at 250 milligrams per day. All of these highlight for us that this patient likely has trichophyte endotheniae. And indeed, that was confirmed by the Bazar Center, New York State Department of Health lab. She does have a drug interaction with itraconazole and finally clears on 8 weeks of griseofulvin. And you can see her terbinafine MIC value here in the L393S squalene epoxidase mutation. I also want to point out that recent recommendations highlight that terbinafine 250 milligrams twice daily is the preferred treatment for T. endotheniae if considering terbinafine, and that this may overcome minimally elevated MIC values. I don't have that data for this patient because she was not treated with that dose, but it is something to realize going forward. The next patient I'll show you is a young woman, has no underlying medical history, and you can see very widespread tinea corporis and tinea cruris. There's prolonged history of this very itchy eruption. No travel and no contacts with anyone who has a similar rash, suggesting the possibility that she acquired this in New York City. She fails 2 weeks of oral terbinafine at 250 milligrams per day, and does finally clear on itraconazole after 4 weeks at 200 milligrams per day. Again, the routine culture identifies T. mentagrophytes, but T. endotheniae is confirmed by the Bazar Center, New York State Department of Health lab, and she clears on itraconazole. Again, pointing out her MIC values, you can see a terbinafine MIC value of 1 and an L393S squalene epoxidase mutation. But we now understand terbinafine 250 milligrams twice daily is the preferred treatment. Again, I don't know if she would have cleared on that because she did not get that dose. And another patient I'll highlight for you, you can see tinea here on the buttocks. You can see crusting and hyperpigmentation. This is a common site for trichophyte endotheniae. He's had repeated episodes of tinea corporis, cruris, and pedis dating back a number of years and has failed 4 months of oral terbinafine. We can again see here that T. endotheniae is confirmed. Now, this patient has a severe drug interaction with itraconazole and cannot take itraconazole. He eventually clears on 20 weeks of griseofulvin. Again, that is not the preferred therapy for trichophyte endotheniae. But when we look at his MIC data, he has a very elevated terbinafine MIC value and an F397L squalene epoxidase mutation. As mentioned before, we could consider 250 milligrams twice daily terbinafine. However, we are now working with his other clinicians to adjust his medication so that we could reach for itraconazole as needed, as that is the most effective therapy for T. endotheniae, especially when patients have failed terbinafine. Now, the last comment I'll make before we move on is a close-up view of the predicted terbinafine binding sites as shown here from the JAMA Dermatology paper. And you can see the A448T mutation, which has been correlated to terbinafine sensitivity in trichophyte endotheniae, falls outside the predicted terbinafine binding site, whereas 2 mutations that confer terbinafine resistance or treatment failure, L393S and F397, are in the terbinafine binding site. So let's end with TM7. And I'm going to show you an overview of a few different papers here, highlighting what we currently understand of TM7, that this is an emerging dermatophytosis, and human transmission is reported, especially occurring via sexual contact. Prior reports link this particular dermatophyte to sex tourism in South Asia. However, recent literature highlights spread within a specific patient population, and that is men who have sex with men, especially as shown in the bottom right, in the paper out of France, and in the paper from Vienna in the top left. Here we see another patient with confirmed TM7. You can see papulonodular lesions and pustules in the pubic region, as well as tinea corporis on the trunk. Tinea pubogenitalis, tinea glutealis, faciae, corporis, and cruris can all be seen with TM7. Inflammatory nodules and scarring are also reported, as is bacterial superinfection, which may require treatment with prolonged courses of antibiotics and antifungals. Notably, patients may first see lesions on the genitalia, and we should keep this diagnosis in mind when we're seeing patients, as it can be confused with other dermatologic conditions. As mentioned, for treatment, patients may require prolonged courses of oral antifungal therapies. Lack of deep infection or fungal folliculitis may suggest the potential for topical therapies, and early detection may also be treated with topical therapy alone. However, patients do require close monitoring. Terbinafine 250 milligrams per day is typically reported as effective for TM7. There is very little susceptibility data reported. And now I'll highlight a paper published in July 2024, the first confirmed case of TM7 in New York City. A young man who recently traveled in the USA and Europe reported multiple male sex partners and visited a spa before developing tinea. Culture here identified tinea digitale, but we know that we need genetic sequencing to confirm TM7, which we are fortunate to be able to get through the Wadsworth Center, New York State Department of Health lab. He improved with terbinafine 250 milligrams per day, although this did plateau, and in discussion with the patient, we opted to treat him with itraconazole. After 7 to 8 weeks of additional therapy, he did clear. And now I'll end with a resources page from the American Academy of Dermatology that you can see here with information about emerging dermatophytes, and I encourage you to take a look at this particular website. You can also find a registry for clinicians. This is the AAD ILDS registry, and there is a location to enter emerging, resistant, and treatment failure dermatophytes. There are many people who have put a lot of effort into making this work possible, and I would like to acknowledge them. In particular, Dr. Gold from the CDC Mycotic Diseases Branch, Dr. Chaturvedi from the New York State Department of Health Wadsworth Center, Dr. James and Dr. Verma, who have been instrumental in helping me understand this infection, as well as many other colleagues from CDC, New York State, New York City Department of Health, NYU, and Bellevue. I'll leave you now with some references on trichophyton endotiniae and some references on TM7. And thank you very much again for your time and attention and the opportunity to be a part of this Fungal Disease Awareness Week.
To our patients. And speaking of practical approaches to our patients, I'm delighted to have Dr. Shyam Verma joining us to discuss practical tips on diagnosis and treatment from his experience. Thank you so much. Over to you, Dr. Verma.
Next. Hello, everyone. I'm Shyam Verma, and can you hear me? All right. I'd like to first talk about the so-called resistant tinea and recalcitrant tinea, because there is a huge difference. Not all recalcitrant tinea are resistant to drugs and therefore, in the true sense, really resistant. There are many difficult to treat tinnias, and they can or they may not be, in the true sense, resistant. This is a relatively new phenomenon. Next. Most people, there are some tips that you should take from some of these points. Most patients that you see of resistant tinea are likely to be from South Asia, and that is because of the travel and migration, probably because the disease is much more common in Southern Asia, where there is poverty and overcrowding. Next. Next. Yeah, this is becoming a global phenomenon, and now there are 42 countries recorded to harbor this. Next. 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 So what exactly does it look like? The most common ones which are so-called resistant are the ones which have been going on for 6 months, with or without recurrence, or in spite of the treatment. There is a steady increase in the incidence, and it's not uncommon to encounter the disease durations running into months or even years. Next, please. This is not very common, and this is what used to be seen in the beginning, active border with clearing of the center. Now it's next. The ones that are resistant are large patches. They are more than one, so they are multiple in number, large patches, and this one has central clearing, but many do not. Next. So you get huge patches which do not have a clearing in the center. So there is inflammation all around. Next. Here is an example, and they're also hyperpigmented. This should open your eyes to this, the possibility of Trichophyton indotini infection. Next, please. You also get areas affected like the face, especially the ear. It's called the ear sign, where the ear is affected sometimes just alone without the facial involvement, and it tends to extend into the scalp margin, and you can see erythema, you can see scaling, but it does not affect the hair follicle. Next. You see children, you see kids, like toddlers and infants who have this infection, which is not seen in the past, but now you can see them. And that is another sign of Trichophyton indotini. Many times these are fairly resistant to treatment. Next. You see erythrodermic tinea, which is a terrible affliction. Next. And many times it is simply because the patient has just been abusing his treatment. Next. Genital tinea should be raising your antenna for the possibility of Trichophyton indotini, especially when it's not responding to standard treatment with terbinafine. Next. Tinea fasciae. Next. Next. You can see that tinea fasciae can present in many ways. Here it's presenting as tinea, as acne. Next. But think of Trichophyton indotini, rings within rings in large lesions. Next. Another example with scrotal involvement. Next. This is called tinea pseudoimbricata, which is ring into a ring into a ring. Next, which is pretty specific for the infection that I'm talking about. And please do remember the role of topical steroid containing fixed dose combinations. Most of the times, unfortunately, in South Asian countries, they contain, unfortunately, the most potent topical steroid, that's clobetasol propionate, with one or two antimycotics and microbial drugs, and one or two antifungal drugs like miconazole or clotrimazole. These are the commonest combinations. And next, how do you diagnose? I would say essentially this is a clinical diagnosis, especially when you're looking at patients who are in resource poor areas. Asking past history of treatment is of great importance. This is for the Western dermatologists. Please do ask for OTC preparation use, because many patients do not consider that drugs. Many times the drugs that they are taking or applying are correct, but the dosage and the duration is not correct. So go into the details of what they have taken, for how long and what. Next, please. Also remember that many of these drugs can be substandard in quality, especially oral drugs like itraconazole, which are the current mainstay of treatment. How do you diagnose on the basis of investigations? So unfortunately, the real resistant dermatophytosis and Trichophyton indotini, a regular KOH and culture is not going to be enough. Even a PCR will not be able to tell you anything more than the fact that it's a dermatophytosis and nothing else. But to know the species, you have to do DNA sequencing. That's the only way of diagnosing this particular infection. And that's why history taking and clinical examination rule the roost. Next, please. This is what topical steroid containing fixed dose combinations can do. They wreak a havoc. You can see hypopigmentation, you can see pustules, you can see multiple widespread lesions which are becoming very extensive. Next, please. Atrophy of the skin. Next. No, go back, please. Look at the side effects of these topical steroid containing creams. The infection is just raging. Patient has developed striae. Patient has developed hypopigmentation on the thighs. He has also got genital tinea. Next, please. Sometimes patients come with Cushingoid features, and you make the mistake of not doing the morning cortisol levels, and you see in this patient, for example, if you see this paper, it's less than 1 microgram, which is grossly HPA axis suppression. Next, please. Next. Unfortunately, these are available as OTC, so do ask for this. Next. So it's a mess, as you can see. There is total chaos. Next. Itraconazole just now is our only hope. Unfortunately, conventional doses do not work. So 100 milligrams once a day, which was recommended for 2 weeks, 1 to 2 weeks, does not work at all in these infections. And you have to updose itraconazole to very often 200 milligrams and sometimes even 400 milligrams for a prolonged period of times. I normally give it for at least 6 to 8 weeks and sometimes even more. But you have to remember the side effects of drug interactions and persistent pedal edema, which is indicative of early CCF. That's congestive cardiac failure. Next, please. Terbinafine used to be the only the first line drug which had a high efficacy, and still many resource poor countries use it. But now the MICs are showing fairly high numbers because of the squalene epoxide gene mutations, and that accounts for the resistance in a large number of patients of trichophyton indotini infections. But do remember that terbinafine in higher doses, instead of 250 milligrams, the drug given twice a day, which is a total of 500 milligrams for 6 to 8 weeks, does prevent the resistance from occurring and the patient starts responding. So higher doses and longer durations can offset the SQLE gene mutations. Next, please. So we have another hope. This is the super bioavailable itraconazole drug, and that is available through some companies which have started making them, where they coat the capsule, which has a more consistent and more predictable bioavailability of itraconazole. As you know, this is a drug which is unfortunately which does not have a very predictable bioavailability, and this beats that disadvantage. You also do not have an acidic pH which is required, so you can give it at any time. Next, please. I usually stick to azole drugs, triazole drugs for topical use. Miconazole and clotrimazole, the old stalwarts, are still around, but I think it's probably more judicious to use the newer ones like sertaconazole. My favorite is luliconazole. You have, in addition, in resistant cases, you can use drugs like cyclopyroxolamine or emerolfin. And it has been shown in studies that itraconazole with emerolfin does have a kind of a increased beneficial effect. Next, please. There are other oral antifungal drugs available when there is unfortunately itraconazole resistance also, which is being increasingly reported, in which case you can clutch at straws and use drugs like fluconazole, ketoconazole, and the newer antifungals, which are normally reserved for more serious infections, fungal infections like voriconazole and fossaconazole. Next, please. So apart from the non-pharmaceutical interventions, you should be encouraging maintaining basic hygiene. Make sure that the towels, the bed linen are not shared. They are kept strictly separate. Even they are not left out to dry on the clothes, uh, whatever you call them, the cables, one on top of the other, because that's another way of infecting. You disinfect the surroundings in office setups, which are in single private practitioners' places, just a table and one examination cot. You can use betadine, and make sure finally that the drugs that you have chosen to treat the patient with are given in adequate dose and for adequate duration, and make sure that the patient shows compliance. With this, I complete my talk. Thank you very much. Over.
Thank you so much, Dr. Verma. We really appreciate it. We have one more talk, and then we will be open for questions. So I think a lot of wonderful points that you made, and I have some burning questions about how we disinfect our environment and hygiene and washing clothes. So thank you. We'll save that for a moment. I'd like to wrap up the presentation of this webinar before we open for Q&A, just to share some information about the International League of Derm Societies and American Academy of Dermatology registry on drug-resistant dermatophytes. And Dr. Kaplan mentioned some of this earlier in his talk. So with that, give me a moment and I'll share my screen. Great. So I'm delighted to join you. As I mentioned earlier, I am the Director of Global Health Dermatology here at Massachusetts General Hospital and Harvard Medical School, where I also direct clinical innovation and education for global health. In terms of my disclosures, I am a member of I'm the principal investigator for the ILDS Dermatology Registry for COVID-19, Mpox, and emerging infections. And I'm currently the chair of the task force at the American Academy of Dermatology for emerging infections, as well as a co-author for UpToDate. What I'm excited to share with you today is the new expansion of our ILDS and AAD registry for emerging infections. So this registry started as a registry for COVID-19, and then when Mpox hit, we added on a registry component for Mpox. And what I'm delighted to share now is that we have a new module for drug-resistant dermatophytes. And I want to thank everyone on this call, because everyone who's spoken so far has actually contributed to the content of this registry and its development. So a huge thank you to everyone for sharing their expertise with us. And this is for healthcare providers to enter cases of either suspected or confirmed drug-resistant dermatophytes. So thank you so much for accessing this. We look forward to collating the data and understanding really frontline healthcare workers, dermatologists, and other healthcare workers around the world that are seeing these cases. By entering data, we will be able to really rapidly analyze and understand our treatment options and diagnostic challenges. So to give you a sense of when you enter in the registry, you can do this from the American Academy of Dermatology website, and I'll also put a QR code in a few slides. You'll see that the registry will ask you to click at the bottom where it says that you are entering a case with suspected or confirmed drug-resistant tinea, and that is how you enter the registry. And the idea of, wanted to share that this effort really came from an international group between the American Academy of Dermatology, the International League of Derm Societies, and the European Academy of Dermatology and Mycology Task Force that really came together. And I also wanted to share, and I know that Dr. Kaplan shared some of this at the end of his talk, about our task force, which is the Emerging Diseases Task Force, and we're so indebted to Dr. Kaplan for his contributions here, where we're really looking at emerging diseases impacting dermatologists and the skin, and really trying to create resources for that. This is our landing page for the AED, and this is free to access for anyone. This is our emerging diseases website. And you'll see that in addition to COVID-19 and complex resources, we also have the newly stood up emerging diseases registry, which includes the drug resistant. So this is one way into the registry. Let's just share with you. And just to give you a sense of some other really wonderful resources, and also a huge thank you to Dallas Smith, who's joining us today from the U.S. Centers for Disease Control, and also Jeremy Gold from the U.S. Centers for Disease Control for their input into these resources. This is on the American Academy of Dermatology website, and I just wanted to point out, in addition to the registry, we have information on recognizing T. endotiniae, preventing and treating T. endotiniae, T-bentag type 7, as well as other resources. And just to show you that we have a really nice page on recognition, some tips for healthcare providers. This is really aimed at healthcare providers, patients specifically. So just some resources from the website to share with you. We also have a suggested algorithm for refractory or chronic dermatomycosis. And I just want to point out there is no international standard for treatment guidelines that's internationally accepted. So really view this as a potential algorithm as opposed to as a treatment, because right now we don't have an internationally accepted standard for treatment guidelines for these issues. And to share with you a QR code, if you are interested in entering cases in the drug-resistant dermatophyte registry and really helping us to share your data, this is a QR code right here, so you can easily access that. And then the short course is aad.org/tinea registry. A huge thank you to everyone on this call, and also to all of these wonderful contributors around the world who have included their expertise in both the registry and also in the resource page. We're hugely indebted to everyone really pulling together in the face of this outbreak and sharing their expertise. So with that, a huge thank you also to my research fellows, Sarah Anwar, Chrissy Lee, and Ann Pacheco for all of their help. And we will now turn it over to Q&A. So I'll ask all of my speakers, potentially please turn on their videos. So we have some really wonderful questions from the field that I'll share. And Dr. Kaplan, since your video is on first, you get to be first here. So a lot of questions that have come through for you. One question was, how does antifungal treatment failure impact immunocompromised patients? And are there any particular approaches that you might recommend to address this?
Great question. Thanks for that question. And thanks for the invitation to be a part of the webinar. Really exciting to be with all of you and to be discussing these topics and learning from all of you too. So I think with and we've had some immunocompromised patients with dermatophyte infections, and one recently with trichophilin endotiniae infection. And I think the approach is largely the same, but certainly working with whoever is prescribing the immunocompromising medication or whoever is managing that immunocompromised condition, whether it's an oncologic condition, a rheumatologic condition, GI, but largely effectively treat aggressively, monitor closely would be my approach. And make sure we have the diagnosis correct, culture, think about the MIC testing, although we know there's no breakpoints for the antifungals and dermatophytes, but largely collaborative and try to work with our colleagues. And I'd be curious what Dr. Verma and others think as well about that question.
Did you want to weigh in on the approach for our immunocompromised population?
Sorry?
Did you want to weigh in on either Dr. Sante or Dr. Verma? Did you want to weigh in on our approach for immunocompromised patients? Any particular considerations?
Unfortunately, I would not comment on that because the immunocompromised patients who come to us, most of them, for example, the organ transplant ones, they are all under care of the medical specialists or other branches of medicine. And we just give them the guidelines as to what should be done, and whether the drugs are safe or not, we let them decide. So I think I'm the wrong person to ask.
Let me switch gears because there's one burning question in the chat for you. Noting that in your report, you mentioned that antifungal resistance testing was only available in about 55% of the European countries you surveyed. Could you share with us, are there any ongoing talks about increasing access or availability of antifungal resistance testing? make this easier? Because right now my understanding is it's actually quite tricky to confirm a case.
I think there's been a lot of work with this since 2021 when we did that publication. First of all, there's now e-tests available more and have been used for dermatophytes with terbinafine. Also, there has been some commercial available kits for detecting mutation in squalene epoxidase. But also, I think there's two big reference labs. The one in Europe called UCAST that has a method, and we have the CLSI. And I think they're working also on dermatophytes and on optimizing methods. So we have different approaches to this. Um, the optimization of the micro broth titer method, which is done in the big reference laboratory, they might give you a breakpoint for each isolate that you got, and the other ones will just screen the patients, the commercial kits, and then we have the e-test, which is not really standardized, as I'm aware yet. I might be wrong, but there is a lot of things going on here, and I think that it's necessary that it is widespread now to more microbiology departments. Yeah.
Thank you so much. Yeah, I'm curious, Dr. Kaplan, in your experience in the United States, about the differences between how testing may be available in the US compared to Europe, for example.
We're fortunate in New York that we have the Wadsworth Center, New York State Department of Health Lab, who's been doing all of our testing, and we've been able to collaborate with in these efforts. Beyond New York, I know there's a few reference labs out there that will do testing, and I would reference everybody back to the resources page where those labs are listed with contact information.
I have a comment to that, because when you talk about that page, it is for AAD members only. So how is people around the world, which is not member AAD, accessing this? Or is that information available in other home pages?
Yeah, so it's actually, even though the website looks like it says members only, it is freely accessible to so it is completely open. You don't need to be an Academy of Dermatology to access it. So you click on the link, it will bring you there from wherever you are in the world. We realize it's America-centric just because it's the American Academy of Dermatology that comes forward, but it is freely accessible. You do not need to be an Academy of Dermatology member. We just have two portions of the AD website. There's public-facing and then there's healthcare providers. I think we have time for one last question. This is a personal question I'm going to steal because Dr. Verma, you mentioned this in your talk, and I think it's such an important one. You mentioned the role of topical steroids. And we know that in certain areas in Southeast Asia and certainly sub-Saharan Africa, there's a huge amount of over-the-counter topical steroid use, also for things like skin bleaching. I was just wondering if you could comment on the relationship between potentially skin bleaching and risks for drug-resistant dermatitis.
Absolutely. This is a raging problem, and this is a short way of increasing the chances of your getting tinea, especially tinea fasciae, when you are using unsupervised topical steroid combinations. You are basically in India, especially in India and in Africa, the common combinations contain hydroquinone with mometasone and tretinoin. So there is a retinoid, there is a topical steroid, a medium to high potency topical steroid, and there is hydroquinone as a bleaching agent. So when you do that, not only are you applying the steroid and lowering the local immunity, the local cell-mediated immunity, you're also creating barrier defects because of the severe irritation caused by these creams, and therefore they're a strict no-no. But in India, you will be surprised that in spite of the craze for having lighter skin, due to which people apply these bleaching creams, especially women apply lots of unsupervised over-the-counter bleaching creams. The problem is more with the creams that contain antifungals antibacterials with clobetasol propionate or betamethasone dipropionate, the two most potent steroids available in the market. They far exceed the number of units sold if you compare them with the bleaching agents. So that is a real issue, and so much so that I was going to send a mail to the CDC saying that perhaps it would be a good idea to ask the customs department, when people from South Asia are entering countries like United States, if they're not only about the oral medications that they are carrying with them, but also the topical steroid containing fixed dose combinations, because this can be a pretty dangerous thing to have, because people not only just buy them, but they hoard them and distribute them all over.
Well, thank you so much for providing such an interesting topic. I love that you brought up the CDC, because I do want to thank our wonderful hosts. Today's been a collaborative effort between the International League of Derm Societies, which is known as the ILDS, and the U.S. Centers for Disease Control. And I do need to do a quick shout out to our wonderful collaborators at the CDC, Dallas Smith and Jeremy Gold, for their work on Fungal Awareness Week and for inviting us all today. With that, I will wrap up. I want to say a huge thank you to Dr. Verma, Dr. Kaplan, Dr. Sante, and also Dr. Khan, who share their expertise with us today. It's really a real pleasure. I learned a lot. Thank you so much. Until next time.
May I?